Welcome to the conference session titled Palliative Care for Supports for Patients. Thank you for joining us. My name is Nikki Ashadu, and I'm the Program Content Manager here at AAMDSIF. As we get started, AAMDSIF would like to recognize the generosity of our corporate sponsors, Diamond level sponsors Alexion and Novartis, Gold level sponsor Apellis and Genentech, and the generous support of our patients, families, caregivers for supporting this conference today. Immediately following the presentation, there will be a question and answer session. When asking questions, please wait for the microphone so everyone can hear the question you are asking. Please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Finley Zachariah. Dr. Zachariah is recognized as a compassionate and highly skilled supportive medicine physician, providing symptom management, pain control, and palliative care for adult and pediatric patients. He also serves as an Associate Chief Medical Information Officer, supporting his colleagues in the adoption of clinical technologies and refining the electronic health record system to improve care delivery. His programmatic and academic focus includes tailoring patient care to individual values and goals, advanced care planning, and leveraging technology to enhance the coordination and delivery of patient-centered medical care in serious illness. With that said, it is my pleasure to welcome Dr. Zachariah.
Thank you so much for having me. So, yeah, I wanted to talk a little bit about supportive care, palliative care, but, oh, can you hear me now? Okay. All right. So I'll stand a little bit closer. But thank you for having me. Wanted to talk a little bit about palliative care and supportive care and also go over some of the myths and some misconceptions people have, especially about pain management. So first, do we need to define pain? I think we all have a very intuitive sense of pain when we feel it. And we also know that there's many impacts of pain. There's a lot of consequences from physical to things like losing sleep, being able to have impacts on walking, intimacy, etc. But also, as you can see on the right-hand side, there's also a lot of concerns here that impact the medical conditions. So that actually impacts treatments like polypharmacy and changes in nutrition, as well as sometimes increasing healthcare utilization as well. From a technical definition, the International Association for the Study of Pain says this is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. That said, we all know that this is really a subjective experience that we all feel. And so, this is just a comedy joke, and with 10 being the highest, you're sure you're only at a 6, right? And so it's really how does each person feel? Sometimes there's things that people may be able to tell. If you have acute pain or pain that comes on suddenly, you might have changes in your heart rate, in being agitated, sweating, etc. So there's some physical signs and symptoms that you may see. But when people have pain that's there for a long time, your body actually adapts. And so sometimes it's also hard where the clinicians might say, well, your heart rate's not elevated, your respiratory rate's not up, etc. Are you really in pain? And there's kind of a questioning effect. And absolutely people can have pain for long periods of time. It's the analogy I give clinicians when I give this lecture is, how many people have ever been mad? I'm sure this room, nobody ever is upset or gets mad. But initially when you get, oh, okay, thank you. Sorry, I'll speak up. Yep, thank you. So yeah, when somebody gets upset or mad, then you actually do get flushed. You get your heart rate up. You're more agitated, sweating, etc. But how many people stay mad for a period of time? Sometimes you can be upset about something for quite a while, right? Weeks, months. And when that happens, then again, your heart rate's not up for all those months. You're not staying flushed, etc. And so that's a good analogy of, especially for thinking about pain, you can have pain or you can be upset for a long period of time. Your body compensates so the symptoms that you initially might show externally don't actually stay there for a long period of time. Also, beyond just thinking about what happens at the tissue level, pain is also really a larger construct. And so there's the physical aspects of pain, but there's also a psychological component to it. There's a social component to it, and also a spiritual component to it. And all of these interplay together to really feed into, what is true pain for somebody. So jumping into some of the myths that people might think about, sometimes people will say, you know what, the goal is really to get to a zero level of pain. I want to have a pain-free experience. And from a medical perspective, that's not what we're shooting for. And so we want to make sure that we're aligning what our goals are and what our targets are for the treatment of pain. And so from a clinician perspective, we're actually looking at how do we manage pain to a level that allows you to engage in your activities and have an acceptable quality of life. So really, even if you have a little bit of pain, that's okay as long as you're able to engage with activities. We don't want to give you so much medications that you actually have a lot of side effects from them. We want to give you almost the least amount possible so that then you're again able to engage and be comfortable. We know that, with some of the conditions that many patients have, especially in the myeloproliferative diseases, there's things like enlarged spleen or inflammation or bone pain that may happen. And so there's different conditions that can, or different treatments that can be leveraged for it. Thinking about how do we optimize your quality of life and goals, one of the big things that we do is we try and assess activities. And so we say, how much, does the pain interfere with your day-to-day activities or with your ability to be able to engage in the things that you want to do? And so if you're able to look and see, well, I'm not able to, even get to the dining room table to be with my family for breakfast, or I'm not able to go out and work or do other things, then that helps us have a gauge on if we can use medications or if we can use other therapies and treatments to help you engage in those activities. That's actually a great use of the medications or treatments that we have, because we're able to make you more functional with them. So just to give you, this is a patient with a blood cancer, but wanted to have you listen to her story.
My name is Debbie Dees, and in 2012, I was diagnosed with multiple myeloma, which is a blood cancer. I had a stem cell transplant, which helped some, but I didn't have, I had to use my own stem cells. So it didn't actually put me in remission or take it away. During that course, I started to have a lot of pain.
Pain has been really the central symptom that we focus on. It's just so in the front of mind for her. And treating her pain it's allowed Debbie to live. It's helped her stay active. It's helped her walk. It's helped her keep working. The wildest thing is that the aggressive pain management has allowed her to get this life-saving chemotherapy.
Palliative care came to my rescue. They came to my rescue with helping me with the pain, following me through. From time to time, things change. It's been a wonderful experience for me.
But we have been able to work with her to alleviate the symptoms as much as possible to keep her doing all the things that make her life meaningful. Hair is what comes to mind. That is everything to Debbie. She shows up to do hair all the time, even on the days where she's having pain. And what we've done is we work together to plan ahead for the pain spikes.
Palliative care knew exactly how to diagnose it and how to help me with the medications and help me move forward in my life.
Debbie is doing really well. Her cancer journey has been remarkable for so many reasons. For me, the most striking is how long Debbie has been dealing with her illness. So this is year 10 of multiple myeloma for her, which is a testament to her strength and also to the incredible cancer care and cancer treatments that exist.
Palliative care has been, it's almost like a new lease on life. It's been wonderful. They've been able to help me understand what pain is. They've helped me know how to deal with it. Palliative care has been magnificent as far as I'm concerned. Like I said, they put me back in the driver's seat.
So I wanted to share that again, just really thinking about the opportunity to focus on quality of life and what do you need to support, you and your family to make sure that that happens. The next myth I want to talk about is narcotics and opioids. And so, the blood cancers are a little bit different in the sense of oftentimes, opioids are not used in general. And it's people who live with these conditions for a long time. And so sometimes it may actually need to be provided to have appropriate support. But from a standpoint of with narcotics and just a lot of conceptions around this, there's a lot of things that are happening now in the news and over the last several years, which is leading to this. So this was a doctor who actually got convicted for just prescribing opioids and benzodiazepines and multiple other medications pretty regularly. Other things are happening though too, where some doctors are now very, very reluctant to give pain medications, and unfortunately, in this situation, a family member actually killed a physician because they weren't able to get access to pain medications. And there's many other things that have actually happened over the last several years as well too. There's been major lawsuits for against drug companies for providing things. There's some abuses of things that are happening as well too. And because of that, it's really put a big damper in a sense on access to medications and access to opioids. One of the things that happened as well back in 2016 was the Surgeon General of the United States at the time, he sent a letter to every single practitioner in the United States saying, we have an opioid crisis. This is a huge, huge problem for us. Please make sure that you're effectively almost limiting the use of opioids, the prescriptions of opioids. We need to really get ahead of this problem, and was very focused on the clinicians as opposed to other places that these kind of things can come from. And so, while it's incredibly important in just in general to limit access to opioids, and there was a lot of very, very good things that are happening for public safety, cancer is different, right? And so it's patients who potentially need these medications and need access to them. And how do we make sure that we balance a public safety approach in the country while also making sure that those populations who need it can actually get the medications that can help them? One of the big concerns that happens with opioids, though, is a question of, can I die? We hear on the news that people are dying from fentanyl overdoses and many other things. And so what I want to say is yes, that is a concern. But if you're actually connected with a clinician who knows appropriate pain management and is prescribing appropriately, you shouldn't have to be concerned. And so, this image here is really trying to represent that you have to actually go through many, many phases in the body before, bless you, before you can actually pass away from pain medications. And so, I don't take any pain medications. If you were to start giving me pain medications, you initially, hopefully I sound and seem alert right now, but if you give me pain medications, I might start to become confused. Then if you keep on giving me pain medications, you go through each of these phases here, where then you can get delirious and then lethargic and then obtunded. And so that means that, say initially I might be confused, then I might be falling asleep and you have to shout to wake me up. If I keep on getting medications, you might have to actually, do something like a sternal rub where you're causing pain to try and wake somebody up. If you keep on giving somebody medications, then at some point they're going to actually be in a coma. And then if you keep on giving so many medications after that, then at some point, you're going to actually knock out the respiratory centers in the brain. So you have to go through all those phases before you actually get to a place where you can cause somebody to pass away. So what happens is, from a short-acting medication, you actually, because it only is in the system for maybe a few hours, it'll maybe cause you to be, a little confused, maybe a little bit sleepy, but then, after, because it's wearing out of your system, you wake back up. The problem can be from these longer-acting medications. So all that to say, yes, there is a real concern with pain medications, but if it's prescribed and used in the manner as directed by your physician, we're very, very aware of this. And we're also aware of what's also happening with a patient, to be able to understand how much can this person in front of me tolerate in terms of medications. Even if they're in pain, we recognize when do they need more, how does their body actually tolerate that? So that then you're able to make sure that somebody is safe, even if you do have to use opioids. There can be many side effects from pain medications: nausea, itching, sweating, sleepiness. Many of those are short-lived and they reverse over a period of time. But one of the side effects that is usually persistent with pain medications is constipation. So this is a bat cave guano, but basically just making sure that if you have opioids and pain medications, you always want to be proactive and stay on top of trying to make sure you don't get constipated. And so we usually like to say the hand that writes the opioid should also be writing the laxative as well. A couple other pearls just on opioid safety, really making sure that, again, you're using it as directed. You don't take more than what's prescribed. Never adjust your own doses. Make sure that you're also looking at it in terms of other sedating substances, so like alcohol, benzodiazepines, etc. You want to make sure that you're not mixing these substances. And just from a safety standpoint as well, there's a lot of concerns now just on, even if you're actually taking it, if you have it in the house, many people have kids, grandkids, etc. And we're seeing that, unfortunately, there's actually like teen parties, for example. Well, they'll say, you can't actually come into this party for, the high school party if you don't bring a bottle of something that says dangerous, could cause harm, etc. And so trying to make sure that you actually lock up any opioids from, the family or from other access to other members is also very important. And so just make sure you think about and are mindful of, if you do have any types of opioids or other types of controlled substances, where can you keep them safely in the home? That'll make sure that only you can get access to them, and others who might visit the home aren't able to access it. And so, again, while a lot of this is a little scary and daunting, at the same time, I want to, also reassure you that there is absolutely a place for opioids. This is, the poppy, which is where morphine comes from, and it's really a helpful thing, especially, as people have certain types of cancer. If it's not managed through other modalities, it becomes a very effective regimen to, again, help with quality of life and making sure that people are able to enjoy and do the things that they want to do. I'll also say that it's really important to have a good regimen around pain management. So this is actually a graph that people use for diabetes. So the brown here is representing sugar levels in the system. And so we all have a certain amount of sugar in our bloodstream all the time. When we eat foods, right, we have a spike of sugar as well. And so when you have diabetes and you have generally good management, you're actually having a medication that's going to provide you a certain level of insulin in your system. So that gives you control all day long. And then when you eat food, you have people who will then have spikes of insulin that they'll give themselves to make sure that they're taking care of those blood sugar levels as well. That's very similar to chronic pain as well. And so you might have a certain level of pain. What are you doing to make sure that level of pain is managed? And then as you do additional activities or something else, how do you make sure that you have something that can help you with that short period of activity or energy that you're exerting? So really thinking about not just the short bursts and what do I do then, but also, what might you need from a long-acting standpoint. But it's not all about pain medications, right? And I think many of you are very familiar with many of the non-pain medication options that are available. So there's things like cognitive therapies that are oftentimes taught and are incredibly helpful. There's yoga has been very, very helpful for a lot of the blood cancers and others that you can see there. The mind-body directed therapies, this is increasingly becoming more and more helpful. And there's more evidence around this for blood cancers. So even they're bringing in technology as well, things like virtual reality, web-based apps that can help with mindfulness and improving techniques, all to really help with pain. Yoga, as mentioned, is incredibly helpful. And then one other thing I'll mention as well with Erin Kopp, she had mentioned, even nutrition is incredibly important. And nutrition, there's actually some studies now looking at, say, the Mediterranean diet specifically, for example, where if you can have a diet that actually decreases inflammation, that also minimizes inflammation that might happen through these diseases. Another myth that people might think about is all pain medications work the same way. And so, here we have many different medications. This is all sorts of different classes of medications that we have, but they all work at different levels of the body, is what this is just trying to represent. And so it's not just about using one medication. Sometimes it's, people really don't like taking pain medications oftentimes, or even, I have several medications, why do I need to have, one more? And so they're oftentimes resistant to taking, okay, why do I need 3 if I can just have 1, for example? And it's really because of this, where, you have different types of medications that work at different levels of the body. And so you sometimes need actually a few different things working together to really provide the most benefit. We also do want to do things in a stepwise fashion. And so we try and start with, the least amount and then increasing from there. And so you'll have different layers of medications where we go from lower things to higher things. For cancer and for the blood cancers as well too, for these adjuncts, it says step 4 here. That's actually oftentimes, maybe closer to like step 1, step 2, when we talk about cancers and how we use them. So we actually will do like step 1, step 4, and then, bring in the opioids as needed. And just to reinforce the needing a balanced approach for pain medications. So for neuropathy, oftentimes people will actually just get opioids. But if you just use opioids for neuropathy, over time, the neuropathy actually can get worse. And so you really need to use anti-nerve medications to help with nerve pain. Opioids can still be used, but it really has to be done again in combination with opioids if you're going to do that. So. I also do want to mention acetaminophen specifically. A lot of people know it by Tylenol, for example. This is not quite in the water, but it's so common of a medication that we want to make sure people are very cautious with Tylenol. While the FDA a number of years ago, they actually said the maximum should be 3,000 milligrams per day from any source, specifically with blood cancers, and knowing that this group might be more impacted by that. I would actually say the recommendation should be around 2 grams. So above 2,000 milligrams of acetaminophen, you can actually increase the amount of blood thinning properties. Normally, you don't think about Tylenol in terms of blood thinning properties, but actually above 2,000 milligrams, it can actually cause some additional blood thinning. So just be incredibly careful. Look at all the bottles, especially if you're using any over-the-counter medications, and make sure if it has acetaminophen in it that you're really keeping track of how much you're taking. Yes. Right. Yeah. So the question is, how many tablets of Tylenol to take per day? So it's going to be by each individual and talk with your doctor about where your counts are and where things are in general. But just saying that the principle is if there's a concern about blood thinning, I would recommend, taking no more than 4 tablets of 500 milligrams, just to make sure that you're not, doing anything further to impact the likelihood of bleeding. Mm-hmm. Yeah, so the question is, we're oftentimes told just to take Tylenol, not take Advil or ibuprofen or other things. And so in general, I would say that that's true. And again, I would just say it's not universal advice for the 2000 milligrams, but just a general thing of making sure that you're aware of even Tylenol, like while it's probably, one of the safer things, it also is has some dangers and risk factors that you need to talk about with your doctor. So. Yep. And that's why I also, just to go back, for a second, there's many other medications that can be used. And so it's almost like low doses or small doses of multiple things then helps to balance that side effect profile while trying to improve pain management. So the other things that, especially when somebody is going to take opioids, they oftentimes are told, take pain medication sparingly when patients can't tolerate the pain anymore. And so one of the things that I tell patients, with cancer is when should you actually take your pain medications? So if you think about pain like a fire, if you think about your medication like a bucket of water, which one would you want to use on? Would you want to use it on a match on fire? Or would you want to use a single bucket of water on the building that's raging? And so, really patients oftentimes will say, I'm going to wait until I can't take the pain anymore. And then I'm going to go ahead and use my pain medications. But at that point, it's really trying to put that building on fire with a single bucket of water. So you do have, medications that you have available to you. Try and think about when you're using it in relation to the pain and see if you can get ahead of it. And the other piece with opioids specifically is that they oftentimes will take a long time to build up. So even at the point that you take it, it might be another 30 to 45 minutes before it starts working. So that, building that's on fire is just going to get worse and worse for another 30 to 45 minutes before it's actually starting to work for you. Again, all of this is really making sure you're doing this under the management and guidance of a clinical team, and so really making sure that you have that therapeutic relationship with them, that you are having that foundation of trust, that you're going to do things in accordance with how they've directed, while at the same time trusting them that if the pain is not being controlled well, you're also able to trust that they'll go ahead and adjust things, whether that's increasing one medication, adding another, to really try and make sure that you're able to get the appropriate care that you need. Another myth is, if I take opioids, I will become addicted. And so, here there's actually multiple facets that we also want to talk about. Where does anybody drink coffee, tea, type of caffeine? So we have a Starbucks here at City of Hope, if you don't know. And so one thing is, if you take something, whether it's pain medications, whether it's caffeine or otherwise, and you stop drinking it, does anyone have any issues? You get headaches, agitated, etc., right? So that actually is what we would call dependence, where if you have withdrawal symptoms by stopping something, that's not addiction. That's actually just means that you're dependent on something. How many people have started with 1 cup of coffee and have stayed at 1 cup of coffee a day? So some people are able to do that, but you hear of other people where, they now are drinking a pot of coffee a day, for example. And so it's not something that happens over days or, hours. It's actually over months or years. You might actually have something called tolerance, where you need more of something to get the same effect as compared to when you originally started. And so that also is normal. Addiction is really the concept where you're actually trying to seek something, or it's really more for pleasure or for some other component as compared to trying to use it for its intended purpose. And so, going back to the Starbucks analogy here, are our doctors addicted to Starbucks? Well, if they're in the Starbucks line and they should actually be in clinic seeing a patient, then you're now neglecting responsibilities to take care of a desire. So that might be a telltale sign for addiction, but otherwise, if you're having withdrawals or if you need more of something as compared to when you originally started, those are physiologically normal for people. There are some tools that we take a look at. This one is actually for really multiple substances, but here these are 4 simple questions that people can be asked. Have you ever felt that you ought to cut down on your drinking or drug use? Have people annoyed you by criticizing your drinking or drug use? Have you ever felt bad or guilty about your drinking or drug use? And have you ever had to drink or use drugs first thing in the morning to steady your nerves or to get rid of a hangover? So if you're positive on 2 or more of those symptoms, then that actually is an 80% likelihood of a potential problem. So, I don't want to know the answers, but if you answer those questions in 2 or more, then I'd be more concerned and cautious about, using opioids or making sure that you're really aware of that with your clinician. And then also if there's a family history or personal history of substance abuse, that also increases, the concerns around addiction as well. But it's not an everyone universal thing. So is also what I'm trying to say. This other chart here talks about what is the likelihood of continuing to have opioid use from somebody who's not used opioids before. And so one thing is saying how much you actually get at the start. So the more amount of medications that you actually take or you receive at the initial outset of having pain, the higher likelihood you're actually going to be on pain medications for a long time. And the other piece is that, just practically, the more often you get refills over a period of time, the more likely you're also going to be on it for a longer period of time. So the takeaway is that if you are able to not have the use of pain medications, or if you're able to minimize it, use it for the shortest amount of time possible is always the better approach here. Another myth could be that support isn't available to help with pain and other quality of life concerns. And so just wanted to play one more short video here.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
So again, thinking about, going back to this earlier slide of pain, it's not just about the physiologic, right? Again, there's the psychological, the social, the spiritual aspects as well. And so as we think about, what's it going to take to help with your pain, it likely is going to take that team approach. And so that's where palliative care or supportive medicine can come in, where we work alongside the hematology experts to really support not just pain, but other conditions as well. And so this is just reflecting that same thing of, you and the patients and the families are at the center, but really you have a whole team that is available to help support in many ways. One other thing I wanted to call attention to was also the caregivers. And so, caregivers, many of us are, whether it's somebody who has, children or taking care of aging parents, or somebody taking care of patients as well. But this is Alexandra Drain. She's the CEO of a group called Archangels. And it's a company that's really focused on trying to help support the caregivers. Short video and then continue.
Archangels is a movement and a platform that is obsessed with reframing how caregivers are seen, how they are honored, and how they are supported. And the data indicates that 50% of actual caregivers don't consider themselves a caregiver or won't call themselves a caregiver. And what they might say instead is, well, I'm just a friend, I'm just a neighbor, I'm just a son, I'm just a daughter. This is what I do. We have an extraordinary partnership with the Blue Cross Blue Shield Association. The Blue Cross Blue Shield Association fields these reports, and they're called the Health of America Report. And this most recent Health of America report, I am so incredibly grateful and ecstatic to say, is focused on caregivers. It's focused on unpaid caregivers. And one of the statistics that it highlights is caregivers have 26% worse health than non-caregivers. And you can imagine the superstorm of negative impact that's going to have, and therefore the amazing opportunity to do something about it. And this is the call to action under which we put everything else. This notion that wherever you are, look around you, because there are caregivers everywhere, and they don't look the way that you would expect, right? 45% are men, 1 in 4 are millennials, 1 in 5 are Gen Z. The most important thing we can be doing for caregivers is saying, I see you, I love you, and here is how I'm going to help.
Great. So yeah, I would encourage everyone honestly to check out this website, Archangels. And it has a lot of resources available for folks as well. They also have something called a caregiver intensity score. And so this is something, if you want, you're welcome to take out your phones and run through your own caregiver intensity score and see how are you doing. And based off of that level of intensity, it actually has, again, resources that are able to support you and your family as well. So with that, want to thank you again for the time and happy to take any questions that folks have. Yes.
Oh, I'm going to bring around the microphone.
On the last slide that speaks to the caregiver intensity score, what is that supposed to assess exactly for the caregiver?
Yeah, it actually is a score that the caregiver would get, basically. So it'll give you a number and almost are you in the yellow or are you in the red, and based off of that, it actually provides some suggested resources that may be able to help. If you're on the more intense side, one, it might be actually helpful to know just for yourself of where am I. And so Alexandra, she gave a lecture the other day, and now she has a kind of code phrase with her husband of I'm in the red. And so he knows, all right, I need to tread on, eggshells, like things may be a little bit tense right now. How do I help support her? And so for yourselves as well, just thinking about where are you now? What can you do to also become more stable? Right. And that then allows you to focus on yourself, making sure that you're solid and then can give more to make sure you're helping others.
Do we have any other questions? Oh, you have none.
It seemed like most of your presentation was on pain management. So I was wondering, is that considered pretty much the most critical issue surrounding uh, palliative care, or are there any other issues that this team addresses, such as, I don't know, emotional needs or some other needs?
Absolutely. Yeah. No, I mentioned it, because it's a little tricky in the cancer space, and it's also, I think, more tricky as well for this specific foundation and the group where you have people who are living with conditions for a very, very long time. And so it's a unique thing of it's almost where people might be undertreated, for pain specifically. But absolutely, supportive care, we really focus on the whole person. And that's done with the team as mentioned in the videos, where we focus on not just the body but the mind, spirit, and how do we really help wrap a whole team around you and your family to make sure that you're in the best place possible. So.
Do we have any other questions? Okay. Well, in that case, thank you, Dr. Zachariah, for sharing your time and expertise with us. We really appreciate it.